I think we can all agree this is a culmination of a day and a half of just tremendous activity and marvelous presentations, excellent discussions, great questions, everything we were looking for as we began to put this effort together. This is our last panel of the day. I know we've crammed a lot of work into everybody, and we apologize for that, but we also beg your indulgence for one more panel. I think you're going to find this very entertaining. These are all wonderful friends of the Carter Center and the work that we have done over the years together, each one of us in one form or another. At this point, I'd like to introduce our moderator for this panel, a longtime supporter of the Carter Center's activities, a woman of most distinguished career, and a member of our Mental Health Task Force, Dr. Mary Jane England.
Thank you, Tom. It is always a pleasure and an honor to be here at the Carter Center and working with Mrs. Carter. She has been a role model for many of us in the mental health field and continues to be, and hope for many years to come. My job today is to have a conversation among a lot of old friends, people that have worked on these issues for decades. And I'm just going to take a minute to kind of go over set a framework which has been set beautifully already by many of the people that have presented to you. Coming from Boston, I guess I always think about John F. Kennedy and his Community Mental Health Center Act. That was 50 years ago, for those of us that still remember 50 years ago, and some of us do. That was the beginning. But it wasn't until the late 70s when President Carter came to the White House and Mrs. Rosalynn Carter made the decision, as she had here in Georgia, that mental health was going to be her priority. And she pulled together a group of people and worked closely, when we'll have an opportunity in a few minutes to hear from Steve Sharfstein and a lot of other wonderful people in Washington, particularly Tom Bryant, who is not with us today, which is sad because he was so much an institution at these particular gatherings. That particular legislation that passed, of course, was vetoed by President Reagan. And although we saw many changes and opportunities, and much of it was presented yesterday by King Davis, we saw the treatment worked. We had a lot of different kinds of treatments, mostly for adults, but increasingly for children. We saw the growth of the consumer movement, and we'll hear a bit about that today as well. The family movement, the importance of families as it related to treatment. We began to get information, as we heard earlier, on the National Institute of Mental Health's work on the cost of comorbidity. We began to see that parity was really a civil rights movement, and Senator Kennedy and Senator Wellstone were very involved in trying to push that forward. The science was growing and continues to grow, and perhaps something that we've talked a lot about in the last 2 days has been the recovery movement. There's science behind what we do in the recovery movement, and it's a very exciting development. What we then saw was some kind of parallel issues are coming forward, and that was we began to see the science on prevention. And the Institute of Medicine in the early 90s had a report on prevention, which Carl Bell and others here in the room were involved with. And then we saw the appointment by President Clinton of David Satcher, who became a real, as Surgeon General of the United States, and who took on the mental health issue in many ways, and had the first White House conference on mental health, and came here to the Carter Center actually to prepare for that. We then moved on to the New Freedom Commission, which Mike Hogan will be talking a bit about today, and talking about the developments and the movements of the public mental health system. A group of mental health practitioners and administrators came together, and they realized that although the Institute of Medicine had a quality chasm report led by Don Berwick, we had never done anything for mental health and substance use. It was all every other group. And so we had the opportunity to have a group of mental health professionals led by Alan Daniels to go to the Institute of Medicine and demand that there be a quality CASM report on mental health and substance use, and I had the privilege to chair that, and some of you in the room were very involved with that. It was a time of excitement because we were gathering momentum to pass the parity legislation. And I actually had the opportunity to be with Mrs. Carter on October 1st when we snuck it in on the stimulus bill. And those of you who work in state and local government and federal government know we can do things like that. So the parity bill was slipped in as the stimulus bill went through, and Mrs. Carter said to me, "I gotta call Jimmy, it's his birthday, and I'm gonna tell him the good news." So it was something that she'd worked for so long. There were many times we weren't up on the Hill to work for parity. And then as we moved forward, the parity legislation passed. And then we had the IOM follow-up on mental health prevention programs for children, which is excellent. And then finally, and last year, Kathleen Sebelius came down here to announce the parity regulation. We'd waited a long time for the parity regulation to finally be submitted, but she came here to the Carter Center to make that announcement. So there have been many exciting kinds of programs that have, over the 30 years since Mrs. Carter's leadership, put forward a piece of legislation that really became the stimulus for lots of other changes that happened in Washington and happened in the field in general. So I'm going to introduce the panelists today, and they're going to come up and share with you some of their thoughts about their involvement and ways they think we'll move forward. And then I'm going to do a question and answer with them. I'm going to take the prerogative, I hope you don't mind because it's getting late in the day, that I will ask the questions and see how they answer them, and I won't ask for any questions from the audience. So our first speaker will be Steve Sharfstein, who runs Sheppard Pratt in Baltimore, and who has very much been an important part of American psychiatry and was very involved with Mrs. Carter in the early days. We have Dr. David Satcher, who is at Morehouse and was Surgeon General and is director of the Satcher Health Leadership Institute. And then following him will be Mike Hogan, who has been the commissioner in 3 states, and who Connecticut, Ohio, and New York, and I had the opportunity to work with him in Massachusetts before he even started that career. And then Alan Daniels, who is been very involved in organizing the American College of Mental Health Administrators to come forward and to really get the visibility at the Institute of Medicine on the quality issues related to mental health and substance use. And then Leah Harris, who is the director of the National Coalition of Mental Health Recovery, and she will and after that, then I will ask them some questions. So we start with Steve. They've decided they want to stand up to give you their, no PowerPoints.
Thank you, Mary Jane. It's a pleasure to see you again, and she's a historic figure, and a number of us on the stage are historic at this point in time.
That's the truth.
Exactly one half of my life ago, a couple from Georgia moved into the White House. I was a public health service officer at the NIMH, and I had the occasion to attend what I think was a Mental Health Association meeting, and the Carters were just president-elect. And Mrs. Carter came to that meeting, and I remember the sense. She walked into that room. I was just a participant in the room at that point, and the electricity that went off, and she came in, and it was clear that she had this interest, this concern, this curiosity, and we felt as a coalition that something was really going to happen. I ended up being essentially detailed down to the President's Commission on Mental Health. Mrs. Carter was the honorary chair. She could not actually chair it because that was not legal for the First Lady to have a position. The chair was Tom Bryant. And I met Tom Bryant, a most wonderful, brilliant, handsome, generous individual. I met Kathy Cade, a brilliant, glamorous, wonderful person. I met all these people, and I'm saying, this is just fantastic. It was an amazing process, a 2-year process, bringing together the leaders in not only psychiatry and psychology, but from all parts of the mental health system, including some consumers. And the process was very important. And in a sense, the Carter Symposia has extended that process. We've had the Mental Health Commission of Mrs. Carter in an ongoing way every year. It's just gone on, and it's that sustaining power that I want to emphasize. The Mental Health Systems Act of 1980 was passed by a large majority in the Congress in October of 1980, Public Law 96-398. I want to emphasize that it was bipartisan. There were lots of Republicans and Democrats that were in favor of that bill. Some of us will remember that the ranking Republican in the House for that bill was a general practitioner, primary care practitioner by the name of Tim Lee Carter, of all names. His last name was Carter. He was very right-wing. I think his district was one of the last holdouts to believe that Nixon was innocent. But he was very interested in mental health. He realized that in terms of primary care, mental health was very important. And I just recall that when they had the conference, there were 2 different bills. The House and the Senate had 2 different bills, and I was in the room representing the administration. I had risen to the highest level of my incompetence at that point. And it was in Senator Kennedy's office, and they appointed Dr. Representative Carter to lead the conference to resolve the differences in the bill, and some of those differences were pretty complicated. And the way they went about it, and they were going back and forth, was that we all stood, nobody could sit, nobody was allowed to go to the bathroom, we couldn't eat, we had to get through it and solve each of the issues, and we got through the legislation, and that legislation was passed. Now, elections matter. And then Reagan was elected. I still think, somehow I wake up in the middle of the night and I say, Jimmy's going to pull it out. I still have that feeling. But he was elected, and as part of the Budget Act the next year, the Mental Health Systems Act was repealed. But elections don't matter, because the ideas and the momentum that was contained in the Commission and in the Mental Health Systems Act persisted. And let me just mention a few. The prioritization of the seriously mentally ill that was in the Mental Health Systems Act became an ongoing issue and concern, the issues of deinstitutionalization, the issues of homelessness, the concerns about care in the community, the questions around criminalization. All of those issues kept going, and now, of course, we have 2 bills, but of course now we've got a very different kind of Congress. Nothing is bipartisan. The Murphy bill and the Barber bill that is, in a sense, the natural extension of that whole process. There was a title on prevention on the kind of the other side, within the Mental Health Systems Act. There was a title in the Act on the integration of health with mental health in the Mental Health Systems Act of 1980, with money to bring together community health centers and community mental health centers in a very organic and real way. And now, of course, through the Affordable Care Act, the issue of integration has finally reached maturity, and it's an idea whose time has come. There was a title on patients' rights. There were many different pieces of the Mental Health Act. The Mental Health Act, in many ways, resembles the Affordable Care Act in that it was an omnibus piece of legislation. It touched on all aspects of the mental health system. It's the people and the ideas and the movement that I think keeps it going and has put us in the situation today where, in fact, things are better than they were, I believe, than in 1979 and 1980 when we had the Mental Health Systems Act. And I think the process that continues and needs to continue on is the answer. At Sheppard Pratt, those of you aware, this was a private psychiatric hospital that had long stays. It's now been transformed into a community mental health center in the model of the Kennedy mental health centers, and in terms of a health system, in the model of the Mental Health Systems Act. And in many respects, I think that my learning curve and my education helped bring into practice in the real world the opportunities for care and the opportunities for recovery throughout the state of Maryland. And I just want to mention that I see Mrs. Carter every single day. How do I see her? I have her picture in my office. Thank you.
David?
Well, I'm delighted to be a part of this 30th anniversary celebration and deliberation, and I personally want to thank Mrs. Carter for all that she's done for this movement. But for me personally, I remember when we were struggling to finish the first ever Surgeon General's report on mental health and trying to make sure that we really had it right and that we were prepared for the way people would respond. She invited me to come to the Carter Center and spend a whole day with the journalism fellows and journalists to talk about what we were going to present. We had not presented the mental health report at that time, but that was really special. I had, as she pointed out yesterday, I had had the opportunity to work with the Carter Center when I was director of the CDC between 1993 and 1998. And one of the things that I did, I was a little surprised when I got to the CDC that there was no program dealing with mental health. So I appointed the first associate director of the CDC for mental health, and that was Marjorie Spears, whom I think some of you know. But anyway, it's been a very special relationship. I had the opportunity to serve on the mental health task force here for several years before I became too busy at the Morehouse School of Medicine. I want to talk a little bit about the opportunity which I had to release 3 mental health reports while serving as Surgeon General. And I should say as Surgeon General and Assistant Secretary for Health, because even though that was a challenge, serving in both roles, only Julie Richmond had done it before. And if you know Julie Richmond, or if you knew him, then you know I was following in very big footsteps. But there was an advantage in being both Surgeon General and Assistant Secretary for Health. I really didn't have much of a budget as Surgeon General, so I stole from the budget of the Assistant Secretary for Health. And I really stole people like Jenna Betts. Jenna was the Assistant Secretary for Health, and so in that whole area, I worked very closely with her. In fact, Jenna and I traveled all over the world. I remember going to New Zealand and Australia and learning from them about culture and mental health, and Australia especially, the whole issue of stigma. I remember speaking at the Rotary Club in Australia, and after I finished, people in the audience started to get up and ask questions, and people would start off by saying, well, Dr. Satcher, 3 years ago, I was diagnosed with bipolar disease. I was diagnosed with schizophrenia. And then they would go on and ask their question. I hadn't seen that kind of thing in the United States. I mean, people don't just stand up in public and talk about their experience with mental illness. So we learned a lot about stigma because in our report we had talked about the barrier that stigma is And when it comes to not only getting people to seek care, a very big barrier for individuals in acknowledging that they have a problem and they need help, but it's also a barrier for families and communities. Parents often think not only twice, but many times before seeking treatment for their children, because they still fear that the negative impact may be better than the positive. I think we're beginning to get past some of that, but it was great to see how Australia had made a lot of progress in that area and gave us confidence that we could too. So the first report that we released was in December of 1999, and it was simply called Mental Health, a Report of the Surgeon General. And I was very fortunate and blessed to have people like Tom Borneman. That's before he got his promotion to the Carter Center. But Tom was a leader on that team, and Howard Goldman. When we released our report, we tried to make a few critical points in that report. One, that mental disorders were real, that mental health is essential to overall health and well-being, that mental disorders are treatable, and we encourage people to seek treatment. It was a very basic kind of report, but it really stimulated a lot of discussion and response. I received letters and calls from people all over the country. In Chicago last week, I was telling a story about the young man who wrote me after we released that report. And he said, Dr. Satcher, when I was 8 years old, my mother committed suicide. And nobody ever talked with me about that. In fact, they never told me how she died, and they thought I didn't know. And so all these years, I've had to just keep quiet and play along with that. He said, but after reading the Surgeon General's report, I decided that I was going to get my family together, and we were going to talk about my mother's suicide and about mental health. And there were several letters like that, but that one stands out in my mind when you think about what people go through and what especially children go through in dealing with the stigma surrounding mental disorders. And so we were very pleased to be able to contribute to that. There's a lot more I could say about that first report. We were asked to present it at the World Health Assembly in Geneva in May of 2000, I believe it was. Presented it to Director General Gro Brundtland. And she was so impressed with it until they decided that they wanted to do a world mental health report. And of course, we decided that the best person we could send to lead that was Tom Borneman. And he did an outstanding job. He spent, I guess, at least 2 years working on that. And did such a great job until he ended up here heading the mental health program at the Carter Center. But Tom, even then, was just such an outstanding scholar and human being until I think that benefited the whole world to have him at the leadership of that. A lot more I could say about that first report, but another report that we did, sort of as a supplement to the first report, was the report on treating children with mental illness. It was a report about mental health and children. And it was done a little differently. We really pulled together teams of people to really look at this issue. And we acknowledge that children live in an environment in which there are several people involved, not just the parents, but the teachers and the coaches and the scout leader. And that in order to really diagnose and treat children appropriately, we had to have all those people connected. So what we tried to do was to model that in the way that we put that report together. Because as I think you know, and we pointed out in our report, less than half of the people who need mental health care in this country actually get it at that time. For children, it's less than a third when we came out with that report. We had some very serious concerns about what was happening to children. So that report tried to lay out a formula for a partnership, a coalition of people working in the interests of children and their mental health. And then with the help of Carl Bell and several other people, we later released the report, Mental Health, Culture, Race, and Ethnicity. And it was interesting because we released that report in August of 2001 in San Francisco at the annual meeting of the American Psychological Association. And it was a really great experience. But then we started to get all of these complaints from the American Psychiatric Association.
Oh, God.
So that was the only report we released that we had to re-release at the annual meeting of the American Psychiatric Association. But it was, in a way, it was a compliment. But I am happy that those two organizations work much better together than they used to, because we have a lot to do together.
Right.
And I'm going to talk about, I'm going to close with a few comments about what we're doing at the Morehouse School of Medicine in that regard. But that was a report in which we looked critically at how race and ethnicity impacted mental health and mental health care seeking behaviors. We pointed out, for example, that while there are no necessary differences in the prevalence of the onset of mental disorders, the burden of mental disorders fall disproportionately upon several groups. African Americans are less likely to seek care. In fact, only about half as likely as the majority population. And Asian Americans are even less likely than African Americans to seek treatment. So that report has generated a lot of effort in that area. I remember visiting a program out in Seattle where they were taking care of a population of primarily Southeast Asians. After reading the report, they took it on themselves that we're going to really get to that population. And they did some very interesting things in terms of getting involved in the community, providing training, developing teams of people, and greatly expanding their patient population among Southeast Asians. So there were some really good things that happened. Well, I stayed in government for a little while longer and then came to the Morehouse School of Medicine. And I've been fortunate to be able to continue a lot of that work. And some of the people who made that possible are here. Our fellows are here, but also Dr. Glenda Wren, who heads our Behavioral Health Center of the Psychiatry Leadership Institute. We 4 years ago volunteered, if you can believe this, to take over the treatment of mental health emergencies at Grady Hospital. And nobody else wanted that job, so we didn't have to compete. But we worked with the Georgia Behavioral Health Program, and we basically tried to improve the quality of care that patients receive and to really study the impact of that. And briefly, we were able to demonstrate a dramatic reduction in waiting time, the use of restraints in the emergency room, and the ability to get patients involved in continuity of care relationships. But I think the thing that caught the attention of Grady administration and others was that we reduced costs by 40% in the treatment of these patients. So it's always good when you can show that you can do good and reduce costs at the same time. We're always careful about claiming that prevention, for example, reduces costs, and it often does. But in this case, intervention with quality care and continuity of care certainly demonstrated that ability. We also have 10 community health centers where we are providing integrated programs in mental health and primary care. And what's so fascinating about that for me, one who trained in primary care, is that it dramatically reduces the stigma associated with seeking care for mental disorders. To have the programs integrated, but it also improves, I think, the quality of care. And again, there are indications, of course, Ben Druss has done most work on this, I think, that it has the ability to reduce costs. So that program has been very important. And finally, we have the Quality Parenting Program, in which we take about 100 parents a year and basically work with them around child development from 0 to 5. Because when it comes to prevention of mental disorders, those are critical years, brain development, all of those things. But we have been very pleased with things that we can measure, like the behavior of children, learning, reading, and things like that. But also what happens to parents. We've been able to show that involvement in that program can reduce the risk of depression in parents in a population that Bill Beardsley and others have shown where depression has been going up, Black women in urban communities. So basically, I feel very fortunate that I was able to serve as Surgeon General and Assistant Secretary for Health, and to be involved with so many outstanding people, and to contribute to an area that is so important to all of us. Thank you.
Thank you.
Maybe I'm making a career of following Dr. Satcher, but there are worse ways to spend one's career. I want to sort of circle back to begin with remarks that King Davis made at the beginning, and he said in an offhand kind of way that he has just gone back to his home in Virginia. I'm back in my home in upstate New York, and it made me think that this is something that is a good thing to do at a certain stage of one's life. But then it made me think that the Carter Center is really our home in the mental health community. And so I want to thank Mrs. Carter, not just for inspirational leadership over many years of our nation's community, but by providing us this home that we are always welcome back at. And then to reflect on some themes of this second presidential commission, the New Freedom Commission, and to make some links between what we did and what we tried to do, and themes that, not just in Dr. Satcher's report, but themes that have been discussed here at the Carter Center over these many years. I have to first acknowledge that I have several fellow travelers here with me, Norwood Knight Richardson, Lark Huang, and where's Nancy? Nancy Speck. We're also commissioners with me in this process, and Howard Goldman was with us in the background, and I'll say more about that in a minute. And finally, Garrett Moran at Westat organized the support behind the commission. So there's a substantial personal, I guess, continuity in this effort. Certainly the premise and the context for our commission was completely different. We did not have a commission that was seated formally or informally in the White House with the First Lady as the honorary chair, and we only had 1 year. Which was very difficult to get things done, and also in a sense, sort of why a commission by a Republican president whose administration didn't go on to headline a lot of things in mental health, and that was partly because the premise of the President's Commission was a little bit different. It was not to try to shape the nation's policy, but it was said quite explicitly to us, and it was in fact in the executive order, that the New Freedom Commission was, in a sense, a gift by the President to the field to be able to shape and reflect on and advance ourselves. So it was a different kind of perspective, one that that was not as lofty, but as we've already seen, lofty intentions don't always quickly result in lofty achievements in the mental health field. So this was a helpful thing. The follow-up also has been sort of much debated, and I think the follow-up is symptomatic of a problem that I'm going to return to in reflecting a little bit on the next 30 years, and that is the follow-up was kind of explicitly left to SAMHSA. So, and it's not, I mean, I am a big Pam Hyde friend and supporter, but you cannot leave change in the mental health system to a small agency.
Right.
So the question of what this means for us going forward, for me, is more important than what it means looking backward. One of the other things that is a continuity, in a sense, with the work that we tried to do with the work that's gone on is that at its first meeting, the New Freedom Commission made an explicit decision that we would try to stand on the shoulders of Dr. Satcher and the Surgeon General's report and use that as a starting point for everything we did. We would not revisit a word that was in there, but we would think about that as a basis for the work that we would do going forward. Another subtle piece of continuity was that Tom Bryant was so helpful to me personally in advice about how to do this work and how to go forward. One piece of advice that Howard Goldman was critical in playing out, and then Howard in his remarks yesterday in the breakout session here talked about the piece that he did with Chris Koyanagi that looked back from the perspective of 10 years after the development of the national plan for what was then unfortunately called the chronically mentally ill, but to see how many of those documents that were not in the glossy report of the Carter Commission, but represented work done by people in the government who had come together to tackle real problems. Almost all of it got done incrementally in federal agencies over time. So without much time and knowing we wouldn't get a lot of headlines, one of the things that we set out to do was to sort of leave behind, and of course government had gotten more formal, clearance has gotten more complicated, and only I think 5 of the 16 subcommittee reports the New Freedom Commission ended up actually getting released by the government. But we had a backup strategy for that, which was Howard had gone on to become editor of Psychiatric Services, and at least half of the consultant reports that the commission contributed ended up being published in Psychiatric Services as products of that work. So another continuity in an idea. Now, Peter Buckley, another old friend, stole one of my lines this morning when he quoted Mrs. Carter, but I want to ground that a little bit. It wasn't that Mrs. Carter talked about the emergence of recovery when the report was released. She was actually responsible for that being the central theme. Now, we were working toward that anyway, probably, but the single most enjoyable evening, I think, for many of us who participated in that was the opportunity to have Mrs. Carter come and meet privately with the commission to tell a few war stories about what it was like with President Carter's commission. But then she said, and as Peter said this morning, she said that she'd been reflecting a lot on what had changed in the 25 years, exactly 25 years as it turned out, between the Carter Commission and the New Freedom Commission. And she said the one change in mental health that is more important than any change over that period of time is that today we know it is possible for any individual to recover. And I think that Mrs. Carter saying that put into words what we were all thinking and feeling, and in a sense that became the headline of this report. So we, again, standing on the shoulders of giants is such a theme in all of this. I want to mention 2 things that were contributed directly or indirectly by President Bush to the work of this commission that are themes that have been discussed here over the years. One is that the announcement of the New Freedom Commission was made in Albuquerque, New Mexico. Why in Albuquerque, New Mexico? Is because the president had gone to Albuquerque, New Mexico at Senator Domenici's request to make a speech in which he endorsed parity. Now, there were people who thought that endorsement wasn't enough. There are people who thought the White House should have lobbied further for it. But in point of fact, the president went on the record to speak in favor, quite movingly and personally, about mental health parity. And the second thing that was not public, but is also interesting, is a reflection that I received one order from the White House about what should be done with the commission report. And actually it was an order about what should not be done. And the order about what should not be done was, they said, don't get into involuntary commitment. We don't want you to go there. This is, think about this, 2002. They said, we've looked at the evidence is equivocal. A lot of people are opposed to it. And so we don't think there's any basis to endorse it at this point in time, number one. And number two, we think if you do that, nobody else will pay attention to anything you do, so we don't want you to touch it. So the rationale may have been partly political, but this theme of, and remember, the new Freedom Commission, this theme is certainly a theme that's been discussed here over the years. So I'll close with a couple thoughts about these themes as they go forward and where we find ourselves now. And as several people have said, and I don't know whether it's an attractive thought or maybe it's not attractive, I don't know, but the notion of when we meet again in 30 years to celebrate things, what will we be reflecting on? And I just want to comment on two themes, that one of which is emergent and we're beginning to address, and one of which I don't know that we have adequately addressed yet. The first of those themes is one which played a significant role in each of the Commission's reports that were here, and that's the issue of suicide. Dr. Satcher also went on, it was not a formal Surgeon General's report, but to oversee the development of the nation's first national strategy on suicide prevention. The Carter Commission talked about it. The report that Alan will discuss, suicide is frequently discussed in there. In 1978, we lost about 25,000 people to suicide in this country. The year 2001, we lost about 30,000 people to suicide. In 2012, we lost 40,000 people to suicide. So I think a test of our commitment and engagement is whether we are able to stem that tide going forward, because we now have some knowledge about things that can be done. Leah and I are both working on this in different contexts. A lot of them go to school in the fact that the Henry Ford health system, when it set out to pursue perfection in depression care, reduced suicides among people receiving care there by at least 70%. There are still debates that say we can't prevent everything. There are still debates that said these methods aren't exactly proven, but a test of our commitment going forward is whether we're going to turn those numbers around, and that's of particular importance because it's at that sharp end of the care system where people can, because of inattention, lose their lives, where also the most coercive methods are used, where we think about this one. We admit people to a psychiatric hospital involuntarily because they're dangerous to themselves, probably dangerous to self by reason of mental illness, probably the single biggest reason why people are committed involuntarily. Yet, when they're admitted, we treat their depression. We do not deal directly with them about their suicidality. So, just some thoughts there about work that's emergent that a number of us are involved in, and if we can turn that tide around, then we'll finally begin to change something that all of these different reports and efforts over the years have focused on. And my final thought about things going forward, and this is a theme also throughout this year's meeting, is that with parity and the Affordable Care Act, we have finally exponentially been fast forwarded into the mainstream. Now, we've sort of been in the mainstream for a while anyway. Medicaid expenditures for mental health care are 80 times mental health expenditures in the block grant, 80 times. Yet we still sort of focus on this sort of relic when we've got mainstream investments in Medicare, in Medicaid, and now with parity in the Affordable Care Act in the entire healthcare system. We have not gotten so good yet at figuring out how to leverage change in that context. And we are thinking about it a lot. It is a theme that's been discussed here. Certainly Ben and others have talked about that. But I believe that when we meet again at some point in the future to reflect back, we'll see change in those two areas. We will have figured out how to save the lives of the majority of people who take their lives now, who don't want to die, but just want help with their pain. And we'll have changed those numbers. And second, we'll have figured out how to carry this work that Mrs. Carter put together for us originally and has shepherded us with over the years to achieve a change for many Americans in their mainstream healthcare system. Thanks.
Thank you.
So it's a real honor to be back here. We released the IOM report here, and it was a very exciting opportunity, and it was actually the timing of that meeting kind of pushed us to get the work done so that we could bring it to the Carter Center to release it. So, Mrs. Carter, thank you for all you've done. Tom and Lee and John, thank you for inviting us. And also I want to note that the Carter Center has also been a major proponent of the pillars of peer support work, which has fostered the role of peers in our systems of care. So thank you for that. I want to do three things very briefly. I want to talk about how the report happened, and Mary Jane said a few things about that. And then I want to talk briefly about what the report said, and then I'm going to do a brief 8-year report card to follow up on where I think we've come. So how this came to be. In 2001, the Institute of Medicine released the report, Crossing the Quality Chasm, a New Health System for the 21st Century. And I remember being at a meeting with Ron and Eric Goplerud and some others, and Eric had this really cool book that said pre-publication proofs, and I thought, how you have a book like that's kind of cool just to begin with, and they said I should read it. So I read it, and basically what it said was that the American healthcare system was broken. It was a failure not of goodwill or intent or hard work, but the system was broken, and without changing the system, you couldn't affect different kinds of outcomes. It had 6 aims: that it would be safe, effective, efficient, equitable, timely, and patient-centered as guidelines for all healthcare. So we started talking about this, and I was asked to chair the summit following that for the American College of Mental Health Administration, or ACMA, and I said I would do it under 2 conditions. One, that we could do it on the IOM report and sort of chide it for its lack of attention to behavioral health care. And number 2, that it had to have a consumer as a co-facilitator, and it was the first co-led summit by myself and Ting Mintz, a consumer. And what we did was we went through the report, and we found there's essentially nothing in the IOM report about behavioral health care. Now, granted, it was on health care, and one could argue that it should be fully integrated, and it wasn't an issue. But it really was, and it was conspicuous by its absence. So Ron and I and some others embarked upon talking to the Institute of Medicine, and at first they said, yeah, well, we'll put on a 1-day workshop to look at that. That's kind of nice, and if you can raise the money, we'll do it. Well, we took it to the field, and what we found was there was a lot of need, a lot of interest, and what started out as a 1-day study ended up as a 1.5-year-long process and a full-blown Institute of Medicine study that generated the report, Improving the Quality of Care for Mental and Substance Use Conditions. So that report basically had 6 sections to it. The first was supporting patients' decision-making abilities and preferences, which was really the rules for how to make patient care person-centered or patient-centered. And the language in the report uses patient-centered because that's what the original IOM report said. Number 2 was strengthening the evidence base for quality improvement infrastructure. The third was coordinating care for better mental substance use and general health care. And as Ben can attest, we had a lot of discussions around this of whether it was coordinating care or integrating care. And where we came down was the notion that it's probably not possible to always integrate care, but it's essential that you'd be able to at least coordinate care across the full health spectrum. That takes into issues of rural health care and underserved areas, so we looked at that. The fourth area was ensuring that the national health information infrastructure benefits persons with mental health and substance use conditions. The fifth one was increasing workforce capacity for quality care. And the final one was using marketplace incentives to leverage needed changes. This report stood on the shoulders of giants, many of whom are on this stage. But what we tried to do was move just out of the behavioral health, the mental health, and into the full continuum of health. So 8 years later, where are we? Number 1, supporting patients' decision-making and preferences. An interesting kind of story. Last year when I went to my primary care visit, the primary care doctor was saying, well, there's this test we thought maybe we should have because of your age and where you're at, but we have this thing now called patient-centered planning and decision-making. And so it's your decision what you do. And I thought that's really funny because we kind of developed that in the behavioral health care world, and they'd kind of taken it over. So we've made some progress in that regard. The whole peer support movement, which the Carter Commission really launched, I think in many ways, has shown progress, has showed promise. You heard from some folks earlier today that it really has achieved a tipping point balance. So I think we're making progress. One thing we might think about this talk is whether it's the glass is half full or the glass is half empty. Strengthening the evidence base, we're making progress. Psych Services just published in the last year a full 14 evidence-based reviews on different psychiatric services. And I think we're starting to see some emerging standards for quality. They could be better with the integration of healthcare, and we still have a ways to go. Coordinating care for better mental health and substance use and general health care. You all should be able to make that assessment from just about everything you've heard the last 2 days. We are making progress, but I'm worried about language that we talk about recovery. General medical care talks about self-care. And so we need to find ways to bridge those gaps and bring those closer together. Ensuring the national health information infrastructure benefits persons with mental and substance use conditions. My own opinion is we're a bit behind on this one, and we haven't really answered the question to what extent behavioral health information should be integrated fully into healthcare information. And there's some people who would argue that if you do that, you perpetuate stigma by integrating that information. I think you only overcome it when you challenge it and say this is an entire healthcare system and it needs to be fully integrated and a part of the same system. And furthermore, I think that electronic health records are ill-suited for population health management, so we need to challenge how they can encompass the entire well-being of people and other providers outside the healthcare system. Increasing the workforce capacity for quality care. We had an excellent panel on workforce earlier, but I'm worried that we have a perfect storm, and we had a presentation on this yesterday. We have parity, we have coverage, we have a massive number of veterans who are returning home, all of who could benefit from behavioral health care, and we probably don't have an adequate workforce to meet those challenges, so we have to find a way to overcome that perfect storm. Finally, using market incentives to leverage needed changes. I think we've made some progress there, but we're still pretty hung up on fee-for-service. We really have not moved to prospective payments. There was some discussion yesterday about the new 223 legislation and some incentives for prospective payment. There's hope, but it's an enormous challenge and one we have to, I think, look towards. So, in conclusion, the IOM report built on the work that you've heard these other reports talk about. It's been said that in research and clinical innovation, the cycle of change takes, depending on who you listen to, between 17 and 25 years. It's been 30 years of these summits, so we should have answered all those problems by now, but we haven't. So I guess I'd like to frame it in a different way. And that is that change occurs by generations. And these reports that you've heard about today have come across or been developed over the course of my professional generation. I'm not going anywhere yet, but that's not going to last long because many of us getting older. And so I guess the challenge is we've laid out a roadmap for the next generation to follow. We've got some good materials, we've made some progress, there's work to do. And my hope would be for you all that you can take a personal pledge for what you can do anywhere from the next year to the next 30 years to move the field forward, inspired by the spirit of Mrs. Carter and the work that she began and the work that's been done on all these reports, and to take a personal pledge to figure out what it is you can do every single day to move the field forward. Thank you.
Thank you.
Those are some tough acts to follow. I'll do my best. I just want to start off with extending my heartfelt thanks to the Carter Center and to Mrs. Carter for your extraordinary commitment to this issue. I'm so tremendously grateful. This is my first actual symposium, and also to be invited to speak is a tremendous honor, so delighted to be here. You know, I have nowhere near the kind of experience as the folks on this panel, but I've been doing this advocacy work for going on almost 15 years. And, you know, for me, it's very much, as an advocate, the personal is the political. I, you know, came up, you know, in a situation where I went through the children's mental health system, grew up in that system, I would say, and it was a system that still promoted that sort of deficit-based, illness-based model. I never heard about the word recovery, and as a consequence, I was 18 years old and was in a group home, an adult group home, where I was told I needed to be for the rest of my life. And not only am I out of the group home, but today I fight to make sure that everyone else gets out as well. So that's quite a journey that I've seen so many other people travel the same path in the mental health consumer survivor and addictions advocacy movements. And I think from my perspective, you know, looking at the history of mental health policy in this country, I've seen a lot of one step forward and two steps back. And that's good in a sense that there's continual movement forward. But, you know, I've seen very much, again, this trend, you know, playing out in my own life. You know, not only do I have my own lived experience, but I'm also the daughter of two parents who were diagnosed with schizophrenia and bipolar disorder. And just to really show the sort of pervasiveness of the stigma that existed back then, and that I would argue still exists now, when my mother became pregnant with me, my family, you know, very well-meaning, really pressured her not to have me. And I'm really grateful for my mother's non-compliance, because otherwise I would not be here today. And, you know, the fact of the matter is that I did not always want to be here. And as someone who's very much struggled with suicide, I completely agree with what Mike has said about how this is kind of the last frontier in a lot of ways. That it's, you know, been really behind the curve in terms of really involving the lived experience of people, you know, who've attempted suicide, who really have this kind of expertise. That's been really missing from the field, but thankfully that's really changing thanks to the efforts of Mike and so many people that are really working at the forefront of the new direction in suicide prevention. And, you know, looking at all of these policy changes through my own life, you know, I look at, you know, my mother, for example, and my father, who are both beneficiaries of deinstitutionalization. So they did not sort of end up in the state hospital for their entire lives as the previous generation had, but it was more of a sort of revolving door situation because of the lack of community support that continues to be a theme that we in the field are all really grappling with to this day. And I want to say that the whatever the varying statistics are, but 8 to 25 year disparity in life expectancy for me is not an abstract statistic. It's really my legacy, and I have lost both of my parents quite young as a result of all the kind of, you know, treatable mental health conditions that we know cause that disparity, or physical and mental health conditions. This means that my son will never grow up knowing his grandparents, and this is part of the reason that I fight every day, so that no one else needs to endure the kind of painful legacy that I have. You know, and in my own life, again, in the 1990s, when I was just coming out of that group home, thankfully, they told me I'd have to be there for the rest of my life. What I wanted most was to get an education. And when someone finally listened to me about that and gave me the kind of supports to kind of get back into my education, graduate from high school, that was really when I began to turn a corner and start to have some hope in my life and get on a path of recovery. But I really coincidentally discovered the recovery movement. It was still sort of, burgeoning, starting in the 1990s, and I discovered the movement completely by accident in the year 2000. And at the time, I was just finished my master's at Georgetown in international diplomacy, and I wanted to sort of become the next Madeleine Albright. That was my dream. But then I found out about this movement, and I said, you know what? This is really where my attention is needed, because I have such a deep personal connection to this issue. And I thought it might be marginally easier than trying to solve Middle East peace, but I actually think I might have been wrong. Time will tell on that one. But I think we could really say that looking back, at the President's New Freedom Commission that has been referenced, I think that's when we can really say that recovery as a concept started to enter the mainstream. And as the report stated, we envision a future when everyone with a mental illness will recover. And so there's been this shift in orientation in practice to the growth of a robust peer specialist workforce. We've seen some really impressive advances in trauma-informed approaches and a number of other practices that align with the recovery model. But I feel the sad thing is that all of this, recovery orientation really hasn't had the kind of teeth that it could in terms of policy. And I would actually argue that today we face a real policy backlash. The Murphy bill was referenced. We really live in a climate of fear today. We've experienced over 100 mass shootings since 2009. In FSU yesterday, yet another one. And with every tragic mass shooting that occurred, we saw in the media and on the Hill this unprecedented level of beginning to scapegoat people with mental illness for the larger problem of violence in our nation. We don't want to address the causes of that, so we're going to pin it on people with serious mental illness. And no matter how much we scream, that people with mental health issues are more likely to kill themselves than hurt someone else, no matter how much we scream that people are more likely to be the victims of violence than the perpetrators, this is not, for whatever reason, sinking into the public imagination. We have a real PR problem on our hands here. And I would say that this backlash is really represented in very well-meaning, well-intentioned Representative Murphy's Helping Families in Mental Health Crisis Act, which he says was developed in response to Sandy Hook. And I really feel that if this legislation went through, it would really undo a lot of the great work that everyone in this room is committed to in terms of a progressive vision for mental health. This legislation is sort of posed as the answer to all of our problems. There'll be no more mass shootings, there'll be no more suicide if we only expand the criteria for involuntary outpatient commitment. And Mike, I don't know, you probably don't remember this, but I testified when I was much younger in front of the New Freedom Commission, and one of the things I said was, shame on you, New Freedom Commission, for not taking on this issue of involuntary treatment. Of course, I didn't know that this was dictated to you. I still admonished you for not taking it on. As we all know, it's impossible to predict who will become violent, and so it's clearly a policy measure that will not prevent future mass shootings. These have been mainly perpetuated by people who wouldn't even have met the criteria for expanded outpatient commitment. And as patients' rights advocates, we're really troubled by this legislation because it's a slippery slope when our civil rights are eroded in the name of public safety. And that we should not be moving towards more forced care as a first-line response. It should be the last response, and in every single possible way, we should try to avoid these kinds of interventions that re-traumatize people who are often already traumatized. Right now, we really have no idea. There's a lot of rhetoric that, oh, there's some people who are too sick to know they even need services. We have no idea whether people would voluntarily use services because they're so often not available. And generally, people are turned away until they're at that crisis point, which fuels our crisis-based system. And the bill would also do away with the protection and advocacy agencies, and as much as we're sort of against that president who will not be named, he did sort of pass the protection and advocacy legislation to really address these abuses in institutional care and try to get people out of institutions and address systemic problems. Similarly, the bill is also very anti-Olmstead by sort of focusing on partially repealing the IMD exclusion, which would be a massively expensive proposition. It would reward states for pursuing institutional care at the expense of voluntary accessible services in the community. And there's a lot of talk about the shortage of beds. But so often we know that it's not necessarily a shortage of beds, it's that people don't know how to access the beds that are available, and then there's nowhere to discharge people to. You know, we've talked a lot about housing here, and that we really need to be thinking about looking at alternatives to creating more institutions and more beds. In addition, this legislation is anti-privacy, as it would relax the HIPAA standards to allow increased access to protected health information. Again, the problem here is not that HIPAA needs to be reformed or changed, it's that providers don't understand the emergency exceptions to HIPAA, and in many cases are hiding behind the law to avoid dealing with families. But for all of my sort of ranting about this legislation, I think Representative Murphy has some really important points that he's raised and that we should all continue to be extremely concerned about. And most important is the heinous way that we as a society have ignored or punished people with the greatest mental health needs. He rightly points out the travesty of the hundreds of thousands of people currently languishing in prison for nonviolent offenses directly related to their disability. He rightly points out about the fact that there are so many people who are homeless today and struggling with unmet mental health needs, and we're not doing enough to address these problems. And this is a common agenda that I think we could all agree on, that we have to give people opportunities to get out of prison, get off the streets, and really have a valued role in their communities again. And that means that we have to fight for housing, this fight that's been going on for so long. And I feel like we haven't won a lot of these battles because of the ongoing discrimination and stigma and this pervasive apathy that hasn't seemed to dissipate despite all of the efforts, the good intentions that have been funneled into anti-stigma work. I think what we need going forward is to have an increasing focus on social justice, which is often not a term that you hear juxtaposed with mental health. But I think it really comes down to collectively demanding that community services are adequately funded at last. Really putting into practice the vision of the Mental Health Systems Act that President and Mrs. Carter so boldly presented. I can't help but think that if the Mental Health Systems Act had not been decimated by he who will not be named, perhaps we wouldn't be where we are today. But we can't dwell on the past. We have to move forward. And I, for one, will be on the Hill educating legislators about where we need to go. And I hope that, I just want to echo the sentiment that we all need to find ways to get active politically if we're not doing so already. I really invite you to make your voice heard about current dueling mental health bills, and to really call for the kind of comprehensive mental health legislation that balances the needs of families and people with lived experience, that protects civil rights while expanding access to and options for voluntary treatment, which is still so non-existent in so many communities. I hope that you'll join my organization, the National Coalition for Mental Health Recovery, and there's so many other people in this room, Ron and so many others who are working together on the Hill to really advocate in the 114th Congress for a vision of real change. What we're asking for is a real expanded outreach and support for people with intensive needs. And peers are some of the people who are best suited to do some of that upstream kind of outreach work to prevent crisis and address crisis. And again, supportive housing. And then really increasing citizenship initiatives to really support recovery by engaging people in the kinds of activities that foster a sense of belonging. I know for me, my recovery was supercharged when I joined this movement and made the decision to come out of the closet as a person with a mental health history and to be part of a movement where, you know, my voice is valued. And I think that that propelled my recovery forward in a way that nothing else really did. Also, really to focus on the kinds of services that young adults want and need. I think that's hugely, hugely important. And to really, again, you know, just to echo some of the themes, focusing on wellness, building a culture of wellness rather than always trying to fight illness. Mindfulness has been a huge, huge factor in my recovery, and there's increasing science behind it. It's not the answer to everything, but we could really think about how to bring in some of these alternative and complementary approaches in a more intentional way. And then finally, jail diversion, crisis intervention, alternatives to incarceration, and reentry programs to really get this criminalization focus firmly into the past for good. As someone who knows firsthand what it feels like to be in the back of a police car for having a mental health crisis, I can tell you it's one of the most dehumanizing experiences one can ever have. And we've seen way, way too many tragedies that could have been avoided, you know, if we were able to reach people much earlier on. So I think I just want to end that I think together in this room, you know, we have the power to really help shift this climate of fear that we're living under and really move it to a climate of hope, because that is the perspective that all of us bring here. And so I encourage you, when you go home, to really engage locally, engage nationally to the extent that you're able, to really push, because mental health legislation, it will likely happen. I don't know if anything we can say that anything for sure can happen with our current state of government, but there's a lot of political will, and we need to get our voices in there and make sure that it's the right kind of legislation to set the stage for the next 30 years. So thank you so much.
Wow, that was really terrific as we saw the progression of the important issues confronting us and the consumers of mental health and substance use services. I've had the opportunity over the last year to chair a panel at the Institute of Medicine looking at developing a framework for standards for psychosocial interventions and recovery and supported housing and employment and peer are all part of it, because we have to have the standards if we're going to be able to pay for all of this. So I have a question for all of you, and that is, in many ways, the Affordable Care Act has given us the opportunity to actually put mental health and substance use on a parity with the rest of health care. And so in some ways, it might be the most important of the mental health and substance use legislation that we've seen over the years. Could I encourage any of you to make some comments on that? What do you think, Steve?
One statistic, in my hospital health system, since the implementation of the Affordable Care Act in Maryland, our uncompensated care burden has gone down by more than a half. We had about almost $2 million a month in uncompensated care, and now it's about $600,000 a month.
Nice, nice.
Now, with that extra money, we have been able to invest in all kinds of interesting new kinds of services for people in Maryland. And I'll just give you one example. For our kids who are being discharged from the hospital and from our residential center, we're able to afford to give each kid as they leave a smartphone. Now, this is a smartphone that doesn't have access to the internet, but gives interconnectedness to us, to the follow-up care, to be able to text back and forth, to actually also be able to locate them sometimes when they wander away. There are a variety of excellent ways that we can try to prevent readmission and get them much more engaged in their recovery. These are kids that are 15, 16, 17 years old from very low socioeconomic backgrounds, and they've got this smartphone. Okay. We're able to afford to do this for now about 400 kids because of the extra money that we have thanks to the Affordable Care Act. Thank you, President Obama.
Other comments?
Well,
David?
Yeah, I think there are 2 or 3 ways in which the Affordable Care Act really enhances the care of people with mental health problems. And of course, it may not seem that way immediately, but I think not allowing plans to exclude people with pre-existing conditions, major for a lot of people, but also allowing children to stay on their parents' insurance until age 26, 25 or 26, because 75 to 80% of problems are diagnosed or can be diagnosed by that time. I think that's major. And of course, declaring mental health and essential mental health services as essential health services. Those are basic. We're not all the way there. We still have some struggles in terms of businesses self-insured, but also we have states like Georgia that are not expanding Medicaid, and that means for citizens of Georgia, a lot of these opportunities will not be there unless we somehow are able to change that.
Other comments? Mike?
Just, first of all, Mary Jane, I just completely buy the premise. I mean, the fact that as both David and Steve have said, the notion that the Affordable Care Act brings with it parity and applies it to everything, and then extends insurance coverage with parity to millions and millions of people, given, with the caveat that Dr. Sadger has mentioned. I also think it forces another issue that I'm still wrestling with, and so I'm going to describe it in a way that is going to be very not PC and may offend a lot of people, but that is that when it relates to the opportunities for entry into care, I think the specialty mental health system is no longer the problem or the solution. I think that the challenge is in the rest of healthcare, and we are not very good at that yet. Now, one of the things that many provisions in the Affordable Care Act will do is, by focusing payment increasingly on the whole person, on things like, so do you think that the co-occurring psychiatric illness of people who are being readmitted for chronic medical problems is related to readmission rates? Well, of course it is. We know that depression alone goes with 30-35%, and Ben has talked about this often, with people with other chronic medical illnesses. So that is eventually going to incentivize other people to say, well, we should be asking about depression or about anxiety in people with these other problems, but we haven't figured out yet how to get over to the other side of the street in the mainstream and be that helpful yet. And I've been thinking about this comparison of care for the brain with care for the heart. I mean, we in the specialty system are sort of like interventional cardiology. That's not the solution to heart disease. No. So the question of how we take advantage of this gift of the Congress and the President to get upstream, to get to people early, is a big question mark.
A couple quick things. The original Quality Chasm report said that the American healthcare system was broken, and it's hard to have a healthcare system without coverage. And so by providing coverage, you open up resources, and there are components within it that talk about changing the way in which we fund care, And so whether that's, as Steve is talking about, reducing uncompensated care and allowing for creative new ways or new models that move us off of, kind of production line healthcare, I think it really opens up an opportunity for change.
Leah?
Yeah, I think there's a lot of hope in the sort of emerging paradigm of the community health worker, and that is, I think, it could be a very exciting new role for peers to really, be involved with helping people to achieve whole health, physical and mental.
I think it was very clear at the last panel that if we're going to really solve the human resource dilemma we have of not enough people trained, that the peer and then some of the social media, and thank you very much for your comments, are really important. In fairness to Ron Manderscheid, he had conducted a session before this session, and everything is not easy. There are some areas where parity is not sufficiently clarified within the legislation. So although there are some areas where we're going to continue to work on, overall, I agree with you. I think it's really a big step forward. On the other hand, how do we feel about this move on the Congress of a well-meaning man who got issues convoluted and now believes in involuntary commitment? Because involuntary commitment is is discussed a great deal in the mental health community.
Well, something that I'll mention that to sort of to go back to Leah zinging me, we actually sort of tried, and my colleagues will remember this, that we had a subcommittee, the President's New Freedom Commission, that was called Rights and Engagement, and it was co-chaired by Dan Fisher and Henry Harbin. Oh my God.
Yes.
And they actually came to really respect each other, and they had wonderful conversations. The hope was that we could come out with a set of recommendations that would talk about everything that might be done up to involuntary commitment. And one of the casualties in the conversation is we sort of go right over here without ever asking people nice, without ever engaging them with a peer, without ever sitting down and developing a relationship, without being able to speak to them in their own language, without meeting them where they are, et cetera, et cetera, et cetera. And then we sort of end up over here. I think if we did all these things, the amount of over this we'd have to do, which I still feel you have to do after you've done everything else, but the amount of it would be infinitesimally small because we'd meet people on their own terms.
I have one more question. It has to do with research. There was a time at the National Institute of Health where we had a set aside for services research, where we actually paid a lot of attention at the NIMH to understanding psychosocial interventions, and yet that has disappeared. Is this a point where maybe we can take that on as a group to attempt to get, I know set-asides aren't popular, but as far as I'm concerned, it is a way of at least protecting a certain amount of money for services research, which right now, most of the money, as we know at NIMH, goes into basic science, I guess you would say. Yes, Leah.
Yeah, I guess most of you know that there was just $650 million donated to genetics research, and I don't mean to discount that. It's certainly important, but everyone admits that that's 20 to 30 years away. And so this is where I feel the social justice agenda comes in about what can we do now, and it's going to take our collective political power to achieve that. So I really think that that is something that is hugely, hugely important, that it's not nature or nurture,
Yes.
We have to understand that it's both, and that we can't have a lopsided focus.
David?
Yeah, I just...
And I'm going to give you the last word.
Thank you. I think what we've been trying to do at the Institute is to conduct innovative services and evaluate them in such a way that they inform policy. Harry Hyman is back there, who heads our Health Policy Institute. And with our fellows especially, what we are trying to do is to really prepare them for leadership in health policy. But part of that is to really conduct what we consider to be exemplary services, evaluate them for their impact in such a way that they in fact could inform policy. Now, somebody's still going to have to advocate for those policies, but I think the more we evaluate what we're doing and show that they make a difference, even sometimes saving money, reducing costs, I think we stand a chance of impacting policy. So we're quite involved in policy from the standpoint of research that informs policy.
Well, I want to thank the panel, and I want to ask you to remain seated while I invite Mrs. Carter up for her concluding remarks. And again, if everybody would just thank the panel. Well, it is always bittersweet when we come to an end of these conferences, but of course we will be seeing you all here in a year from now. And Mrs. Carter continues to be our leader and our strength as we move forward in the fight for services for our clients. Rosalynn, thank you.
You can see from this symposium what great people I've had to work with over all these years. It's been really nostalgic for me looking back, seeing so many people that I've worked with over the years, seeing so many people here that I've worked with over the years, and looking back at some of the things, the dramatic changes that have been made in recovery and coming together of mental health and substance use, and it could go on and on. And one of the other things that this list, these talking points that I had, was the remarkable development in our society, the blossoming of the consumer movement, and that's one of the great things. It's another one of the great things that has happened. We've heard today, these last 2 days that have been great, another great symposium, and we've heard that there's a lot of thought already going into the directions we can take in the future. That's interesting to think about. And I'm not going to go over everything that we've done, that's been done, but one thing I did want to say was that we've done things a little differently this year. And this is kind of housekeeping, but we look forward to hearing your reactions and suggestions in the follow-up of online survey. It's really important. We do look at it, and we do take the suggestions and try to make each symposium better. And it's very helpful to us to know what you like. So we look forward to hearing from you for that. Well, it's just been great. So I want to thank to thank the funders first again, SAMHSA, Optum, and the Charles Engelhardt Foundation, and many other individuals who've given, which has made it possible for us to do this. And I want to thank the Planning Committee. It's been a great session. And all of those who participated. I'm not going to name who they are. You know them, the panelists, the presenters, and the staff. I think, will the staff members please? I think they all, okay. Great. And Tom. Let's give Tom a big hand. Well, I have some news for you that I think is good, too. It's not, we haven't talked about it, but do you know who Jeff Skoll is? Does anybody know who Jeff Skoll is? Jeff Skoll is a filmmaker. He did the film on issues like the environment, Al Gore's environment. And he does the video, the film, the movie. And then he does a follow-up all over the country on the issue. It's all on good issues. And I got a letter from him saying that he was going to do one on mental health. And he's going to focus on recovery. And so He gave me a name. He gave me a name to call. The way I know him is that he's a funder for the elders and the elders organization that Jim is a part of, and he comes to the meetings and I go to the meetings, so I've gotten to know him pretty well. And so we got. He gave me a name of somebody to call, and I tried to get this person. Well, he said he was going to have him call me. He didn't call me, and so. I tried to get in touch with him. I found out later that he was the head of his whole organization. And so now we've gotten in touch with the person. He's given us somebody to work with. And we've got a conference call with him on December the 1st because they're having trouble finding people who will talk about their experience. And we've got anything he needs, we can help him with. And so I am so excited. And Kathy, I was just thought when I was thinking about telling you about this, that he could do stigma. He wants to do those who are recovering and showing how people can recover and live good lives. And I think that could lead into stigma. I think they're open to suggestions. They're kind of feeling the way to go on it. He's going to do another film on people who are different, and we thought we might even could help him with that too. Anyway, that's exciting to me, and I wanted to leave you that because I think that's really good news, and the follow-up is going to be so good too. So I'm happy that you all were here. I do thank everybody, not only for what you have done these last few days, but for what you have meant to me over all of these years. And have a safe trip home.
Thank you.